Today I want to share with you this multidisciplinary treatment and management with the training. As you saw that we are all talking about the radioligand therapy, and we need to answer for whom will be this using, because it was starting from the beginning that even our first the treatment with the radioiodine is radioisotopic treatment, but now we have the most sophisticated the treatment for this radioligand therapy, and we have two randomized trials. The first, it was mentioned by Professor Ken Herman and Nicola Frazzi, that NETTER trials for these neurocrine tumors, which provide us that very good results with reduction, 79% of reduction of risk disease of progression or death, as well as significant improvement quality of life. And this very recently published the vision trials for this castration-resistant prostate cancer patient. The same, very good results, nearly the 40% reduction of the death and 60% reduction of the risk progression. Both of them had significant improvement of survival parameters. If you look for this kind of the therapy, first of all, we need to answer that we want to treat the patient with the personalized treatment and personalized imaging. But for this, we need to answer what for us is exactly the tumors. And probably most of you know that we are dealing on the beginning with not, that's an easy game, because we are talking about the polyclonal tumors. That means that of course, we have the histopathology, but histopathology is made by the primary tumors or with the small sample tissue. But during the disease, there's different is the behavior of this kind of the tumors and different phenotyping. If you have the image with this different kind of the phenotyping of the cells, basis on this phenotyping imaging, we could use it with this our nuclear medicine techniques. We could on this based place the targeted therapy. And it was mentioned several times that is exactly the basis of targeted therapy. That means the image-based therapy. Why we need this phenotyping imaging? We have the example, very well known, somatostatin receptors positive in neurocrine tumors. And we know that the majority of this well-differentiation tumor are expressing with the somatostatin receptors and are not avid with the FDG, which give us metabolic behavior of the tumors. But during the disease, we could see that these tumors could be differentiation as well. We have the different clone of the tumors. And this is the scale proposed by the Australian groups, with, as you can see, the 5 points of the scales, where you could see this somatostatin positive and FDG negative. On the end, we have somatostatin negative and FDG positive, but we have a lot of the variety between them. What it is important for us that this phenotyping give us very strong impact for the survivor of the patient, as you can see on these graphs below. And the same nearly the experience we have now with the prostate cancer patient. It was the first example for this phase 2 phase 2 trials, as well as this procedural guidelines for the EANM. You could find that to qualify the patient for the therapy for this PSMA base, we need to check not only that we have the expression, but how is this expression, because the patient with the low expression will not benefit with our therapy. As well, during the disease, we could see this concordant FDG and PSMA scan. And what we know for the vision trials, as you can see, that nearly the 30% didn't meet the criteria for the PSM therapy. Professor Cherny showed us how is this impact of this for this budget perspective. But for us as a physician is the most important thing that primo is non-nocere. And second is the regulatory safety of the patient. That means if we treat this patient with the agent which is not which is not good for this patient, and the patient is not suitable for the therapy, we didn't achieve the therapy effect and will we have only the side effects. As you see, this process is quite complex, and for all of this, we need to have the multidisciplinary team. We need to sit together, we need to discuss, but we must think that in the middle of us is exactly the patient, and we must think about this personalized therapy. So how it should be this composition of this team? First of all, it should be the clinician. It depends on the disease, endocrinologist, urologist, gastrologist, which give us the history of the patient and who will be the starting point for the diagnostic image. For the diagnostic image, we need both. We need the radiology, which gives us the anatomical imaging, as well as I told you, and I showed on my this presentation on the beginning, we need this phenotyping of the tumors with this nuclear medicine techniques. Together with clinician, with the images, probably will be meet with the oncologist, and they starting to discuss what is possible for the treatment for the patient. Of course, always, if it's possible, we will think about how to use the surgery. If it's localized disease, but this is any contradiction for the surgery, we could think about the radiation therapy. But if you have the disseminated disease, we need to think about the nuclear medicine and possibly to use the radioligand therapy. First of all, if we talk about the radioligand therapy, we need to tell them that it is different. They are thinking that it is like the normal drug, which is produced in the one place and it could be sold over the world. But with the radionuclide therapy, it's a different story. We have the isotopes with this short half-life, and it is exactly produced for this particular patient. And this treatment can be, the storage for this more than usually 24 hours. Even we have the half-life of the isotopes longer, the stability of the products is quite short. That, as you can see, we're always talking about the time. Even with this nuclear medicine, it is hidden, this multidisciplinary team. Because as I saw you, on this multidisciplinary team for the discussion about this patient way, it's usually presented by nuclear medicine physician. But to manage everything in nuclear medicine, we need to be more multidisciplinary, and that is something which is hidden behind this. We need to have this radiopharmacy. First of all, our radiopharmacist must prepare for us the agent for the diagnostic approach. It was mentioned several times, it's majority this with the gallium, that means very, very short half, 68 minutes, and it needs to be production on site. With this therapeutic agent is that it could be the supply, but always we need to think about this availability, about the production, and that delivery time. Majority of the European countries, as well the US, we have some kind of the regulation how to use the radiation. And if we talk about the cancer patient, we usually need to have for this special nuclear medicine department wards with some regulation, with the dosimetry requirements. And please remember that we give patient radioactive substance. That means that all this waste from this patient is radioactive, and we need to think about some tanks collection and waste management. And of course, that's all the staff who is working with them. That means the nurses, technologists, they need to have this educate how to deal with this patient. And this is the example what is the hidden with the dosimetry approach. And with this, we, of course, they absorb, first of all, patient. And for the dosimetry, to calculate the absorbed doses, we need usually the 3 to up to 5 this post-therapeutic scan. And that means that we involve for these technologies, but very important and very difficult after this is working of the physics. You could see that we need to determine the organs of this delivery of these doses and calculate the curves of the absorption to see what is the absorbed doses and the risk organs as well in the tumors. This is really time consuming. It usually takes between 5 to up to 5 hours. On the other hand, we have in this multidisciplinary team, we have non-nuclear medicine components. That means that the people who are sitting together with us and discuss with us about this patient who will be eligibility for this our treatment, that need to understand what we are talking about. That need to understand that after this injection of this radioisotope, this patient will be radioactive, so he or she needs to stay on special nuclear medicine department ward with all this rule of radiation safety and patient management. And they must understand that the people with these mental disorders, with depression, sometimes doesn't meet this criteria to stay for these 5 days of the isolation. And of course, they need something that we talk about, that's the patient selection, that not each of the patient will be qualified for the therapy, because this is exactly based on the imaging. They need to understand our radiopharmaceutical logistics. That means that we have the delivery on this particular date. It is not available on the date. You are, depending on the production on the reactor or cyclotron. That the patient needs sometimes stay longer on this department for the dosimetry requirement, and also with this waste management. So, who needs this education and training? As you see, that is a very complex and very difficult process. So all the members need this education, but this education, it should be specified on the field of expertise. What we are doing as European Association for it, we are organizing some events through this European School of Multimodality Imaging and Treatment. And this is this courses which was organized that year with the live webinars, online courses, as well in courses in Vienna. We organized together with the ESMO the joint course of the theranostic. Even more we have in our pipeline for this 2022. That you could see that the theranostic using this artificial intelligence and quantification is really important for this live webinars, for this online courses, and as well for advanced course in Vienna. We are planning in July 2022 the repetition of the joint course of the theranostic together with ESMO. Even more, we are deeply involved. We just received the grants that together with this whole the consortium members, we apply for this Erasmus grant about this education and training for the radionuclide therapy, and we established Radionuclide Therapy Academy. And that project has the gain to map the knowledge about this radionuclide therapy in Europe, as well this launch dedicated training program there. So this is all this learning curve that we are proposing. The starting for this live webinars with online courses, advanced courses, but please remember that the most important is practical training, and the most important is understand to each other. And with this, we need to understand each other for this multidisciplinary team. Thank you for your attention.